I'll introduce Jennifer. It's actually a pleasure to introduce my associate, who I've known for a long time. She has taken on a great part of our practice, and that is working with our patients who have allergies, which contribute to any number of ear problems, and including she's done a great deal of work with autoimmune and with Meniere's disease that can be triggered by some type of allergic reaction. She's kind of been expert in this area and has done a wonderful job of building up a great practice and great reputation. I am also proud to say that she was first woman president of the American Academy of Otolaryngology in 2004. And I always like to say it was 100 years. The first woman was inducted into the Academy in 1904, and it took 80 years before we had a woman president. So we were all very proud of Jennifer. So Jennifer, take it away.
Well, thank you. Let me get this down and I'll share the screen with you. Hopefully, or either that or I'll lose everybody. This lecture was actually requested by Laura, Dr. Christopher. She was having a hard time sleeping. As a matter of fact, on this, and just saying she was having some difficulty, and I mentioned to her I had found a perfect cure for this, a sulfuric that she would really like. So I shared it with her. She was very impressed, and then suggested maybe I should put this on, because for some of you others that are having insomnia problems, this could be of some benefit to you. So here it is. When I came to House Air Clinic, and after I'd finished an allergy fellowship, I was surprised, to say the least, to see my associates giving patients with Meniere's disease, and especially those that they thought were allergic, histamine. And I was appalled. I thought, histamine is bad. This is what I'm supposed to help counter here. So why are you giving these to these patients and telling me they're allergic? So knowing that I knew more than the collective brain trust of all of my associates, I started to, I began to promptly discontinue the use of histamine on Meniere's patients. And after a few dozen of them called in with severe vertigo, totally out of remission with this, I thought I don't know what it's doing, but I better start putting them back on it. So that led to my curiosity about it. And having looked at this, I've been impressed at the role that histamine plays and how many good things that it does, of which most of us are clinically unaware. So I hope in this presentation, what I can do is work through that with you. And is this, John, I can shut off this. Is that partially blocking my screen?
Oh, you're okay. You're okay.
The lectures are okay. A disclosure on this, we're going to be talking about the use of a non-FDA product, beta-histine or histamine. These are my relevant disclosures, none of which I think are relevant, but here they are. And what we'll do in this presentation, we'll discuss the evolving role of histamine in disease treatment. And we're also going to review the varying types of histamine receptors and their actions. And then finally, what we'll do is we'll review a role for histamine, I think an increasing role in the day of COVID. Get that back on. Histamine was first recognized a little over 100 years ago in 1910. Dale and Laidlaw recognized that there was some substance that mimicked anaphylaxis. They later isolated the histamine from lung and liver tissue and decided to name it histose or histamine after histos, Greek for tissue. Now, speaking about having difficulty sleeping, at the end of World War I, along with the Spanish flu, there began to be a plague across Europe that they termed encephalitis lethargica. And I think we can all pretty much figure out what the symptoms of that were. So a Viennese neurologist, I'm probably saying this Spanish and not whatever language, Italian or whatever it is, but it's von Economo, observed that there was a direct relationship between the degree of sleepiness of these affected patients and a lesion or site, a particular site in the central nervous system. And the worst of these had an effect, the worst had lesions, the worst patients that were in the posterior hypothalamus. So he theorized that somewhere within the posterior hypothalamus, there must be some kind of wake promoting neurons. In 1937, Beauvais and Stowe identified the compound that was able to block histamine-mediated anaphylactic reactions. I put the name there in boldface because he actually won Nobel Prize, as did another researcher, for the work they did on antihistamines. So what is histamine? It's a biogenic monoamine synthesized from the amino acid L-histidine, and it's produced at two sources. There's a primary source and there's a primary peripheral and a primary central source. And the primary peripheral source is at the mast cells, basophils, and in the GI enterochromaffin cells. The primary storage site, again, I think most of us are familiar with this, is at the mast cells and basophils. The primary central source of histamine is indeed in that tubomammary nucleus in the posterior hypothalamus. And also we do have mast cells in the brain. And histamine is also, that's also a source of histamine. And I'm going to segue into this, that actually the most common symptom of allergy is not nasal congestion, which is number two, it's fatigue outside of what one would expect. So we've known clinically for a long time that histamine itself could have some effect on wakefulness and alertness in the brain. Histamine plays a role that's both immunologic, I think most of us are familiar with that, but also physiologic. Why do I put this on? Because if you're like most of us, including me, when I came to house, histamine was nothing but bad. I mean, it gave you all kinds of horrible symptoms, sneezing, itching, running, etc. It gave you heartburn. And of course, we're all, the guy down here is getting his COVID-15. It looks like he's doing more than COVID-15 before he takes his antihistamine Zantac here. And what we were all taught via commercials is it's bad, it does horrible things, take antihistamines, everything is cured. So we nuke it, we block it with an antihistamine. Harner and Harris did show early on, before the isolation or before the discovery, if you will, of antihistamines, that histamine gave headaches if you infused it, gave it an IV infusion. And there have been multiple sedating and non-sedating antihistamines ever since antihistamines were introduced in the 1930s. So what are the effects of histamine? Physiologically and immunologically, I think most of us, hopefully after you get out of an ENT residency, you are familiar that histamine can cause allergic symptoms, inflammatory, vasodilatation, nasal capillary dilatation, such as to produce nasal congestion, gastric acid secretion. It also, though, is an important physiologically, has an important role physiologically. It's involved in neurotransmission, very involved in wakefulness, as we'll discuss, essential for normal balance. And actually, it plays a role increasingly recognized in suppressing the appetite and even causing lipolysis of fat, in addition to enhancing cognition. Get that on back. So the most common effects that we think of histamine are peripheral. As I mentioned, histamine is synthesized, it's stored, and it's released by the basophils, mast cells, and enterochromaffin phils. And histamine is going to bind on the peripherally, it's going to bind to one of two receptors, either an H1 receptor or an H2 receptor. And I'm going to go clarify that in just a moment here. And it's going to regulate which receptor it binds to, is going to regulate the immune response. If it's for peripheral effects of histamine, if histamine happens to bind to what's called an H1 receptor, you're going to get allergic responses, the sneezing, the itching, the running, etc. If it binds to a different receptor, the H2, histamine 2, you're going to get gastric acid secretion. Now, what are the, I think I may have slipped aside. Yeah, I did. I slipped a slide right here. I'm going to go back on this. The biologic, these histamine effects that I discussed, what biologic effects occur are actually depend on what histamine binder, what binding site histamine binds to, and there are 4 of them: H1, H2, H3, and H4. And the binding can result in any of these with either a central or peripheral effect. I'm having all kinds of challenges with this. So the peripheral effects on this, again, what we're familiar with: vasodilatation, increased capillary permeability, which causes nasal congestion, eye puffiness, etc., pruritus, conjunctivitis, etc., and bronchial constriction with asthma. This is bugging me. I'm just going to negative. Okay, got that down. Okay, the H2 effects of histamine, though. If histamine binds H2, the peripheral effects that we're going to have are going to be gastric acid secretions. And of course, we take advantage of this by using H2 antihistamines for treatment of gastric acid and GERD, famotidine, ranitidine, cimetidine. I'll make a note that that ranitidine has been taken off of the market. It's been recalled after low levels of a carcinogen were found in it. What are the central effects of histamine? Well, as I mentioned, it is a neurotransmitter, very important in both the wakefulness and in balance. It has, it's the primary role, central nervous system role of histamine is to provoke wakefulness and rapid eye movement, sleep suppressing effects. It also affects feeding, endocrine activity. Its central effect is to decrease appetite. It may actually lessen the development of leptin resistance, and then from that, fatty diet-induced obesity. We should have all been using histamine, I think, during the COVID pandemic. And it does seem to accelerate lipolysis. So let's look at the role of histamine as a neurotransmitter. It's synthesized exclusively, centrally, in the histaminergic neurons of the posterior hypothalamus. That early observation was correct in World War I. The central effects are mediated, again, by 4 different types of histamine receptors: H1, H2, H3, and H4, all of which are expressed in the brain. The first generation antihistamines are specifically H1 receptor antagonists, and they're used to block both peripheral, allergic, and then central effects of histamine binding to the H1 receptor. When histamine, as mentioned, binds to the peripheral symptoms, when histamine binds to an H1 receptor, are allergy symptoms. Again, the rhinorrhea, pruritus, all the symptoms of allergic rhinitis. When histamine binds to an H1 receptor in the central nervous system, then it promotes wakefulness. Now, the first generation antihistamines that were produced had both effects, peripheral and central. They would cross the blood-brain barrier and the blood-labyrinthine barrier. And the effects that we had centrally were both bad and good. The good effects, the good central nervous effects of first generation antihistamines were sedation when that was desirable. And in fact, almost all of the over-the-counter sleep medications that we use are H1 antihistamines. They're also, as we know, the most common class of medications that we use for the treatment of vertigo. Meclizine is, of course, a first-generation antihistamine, as is diphenhydramine. The medial vestibular nucleus of the brainstem is believed to be the primary site of action of these H1 antihistamines and the receptor sites. So what's the bad side of that? The sedation. If we don't want to fall asleep, we take an H1 antihistamine, our nose may feel a whole lot better, but we're also going to fall asleep, like many of you are probably doing it just at this very moment. And also, you may not be aware, but the chronic use of first generation antihistamine H1 blockers, such as Benadryl, is associated with the central effect of weight gain. So what about the second generation antihistamines? Good and bad. Good, they don't cross the blood-brain barrier. They don't cross the blood-labyrinthine barrier. So they're largely sedative-free. And they also don't cause apparent weight gain. They primarily give peripheral effects. These are ideal for patients with mild allergy symptoms. But because they don't cross the blood-labyrinthine barrier, they are not useful for the treatment of central nervous system symptoms of allergy. They're not useful for allergically induced vertigo. We don't use them for insomnia. And I have to say, it drives me crazy when I get these referrals in from outside where a patient is said to have allergic, allergy, and they have Meniere's disease. So the treatment has been with some Allegra. It just isn't going to help anything. That's at least in terms of the Meniere symptoms here. But these are very good medications, again, for the nasal and dermatologic effects of allergy. Okay, what about H2 receptors? And again, there are central and peripheral effects of histamine binding to an H2 receptor site. The peripheral action stimulates gastric acid secretion, and we use an antagonist to that, an antihistamine antagonist, H2 blocker antagonist, to block gastric acid secretion. Ranitidine, famotidine, they're both H2 receptor antagonists. And this is just, again, off-label with this, but famotidine and this class of medication seem to have a synergistic effect if you combine them with an H1 antihistamine, if you're treating patients with urticaria. And I hate it when I get patients in with urticaria because I'm not a dermatologist and just trying to figure out what to do with them. But this is often, some Zyrtec and some famotidine, ranitidine when it was available, often has a real good effect on that. So what's the central effect of H2 binding? Well, you fellows, if you think you have a bad job, imagine if your job was to sit in a laboratory and make a dose response curve as to how much mice fight with each other. The central effects, who knew the central effects of H2 receptor binding are it mediates aggression in mice, apparently not humans, but in mice. And there is a direct linear relationship between histamine expression and aggression in mice. How about the H3 receptor? It gives central effects. And it's important in it's important because it's found in many brain structures, especially pertinent to us who are treating patients with dizziness. Cortex cerebellum, hippocampus, amygdala, basal ganglia. It is H3 receptor is considered a heteroreceptor because it also regulates the release of other important brain neurotransmitters, not just histamine. And H3 receptors are the receptor that's going to determine what the function of histamine is in the central nervous system. And this may sound counterintuitive, but there is a feedback loop here. When histamine binds to an H3 receptor, it inhibits the release of histamine from histaminergic brain neurons. And so let's repeat that. If you have histamine and you bind it to an H3 receptor, it inhibits any further release of histamine from these areas in the brain where histamine is produced. So what happens if we block that? If we use some kind of an H3 receptor antagonist, well, that actually results in an enhanced release of histamine. We're blocking the effect. It also, though, leads to an enhanced release of acetylcholine, dopamine, and norepinephrine. And those are the factors that are so important in enhancing the cognition that histamine is capable of doing. And there's a lot of research right now on H3 blockers. H3 blockade may actually play a significant role in the treatment of ADD, Alzheimer's, schizophrenia, and even obesity. And from our standpoint, what we're interested in is what happens if we do a blockade of that H3 receptor in terms of our patients with dizziness and in particular Meniere's disease. The H4 receptor, I'm just going to put this up to say it has a central inflammatory effect. I just put this up just for your reference. We're not really going to touch on it again. It may be a future target for amine-mediated inflammatory conditions. So let's just leave it at that. Let's go back to H3 though. So our primary H3 antihistamine is actually an analog of histamine. I tell patients trying to get, creative with the description here, I try to say that it's, it's a synthetic antihistamine, it's a synthetic histamine. So what it does, it's actually very fortunate for what it can do for patients with Meniere's disease or any allergy patient. It only gives a mild H1 effect. So it's not common to get patients on beta-histine. They get the sneezing or itching or GI upset with it. You'll get some, but not very many. But it is a strong H3 receptor antagonist. So what it does, the use of beta-histine, it's going to bind into that histamine receptor site, that H3 receptor site. When it does that, that's going to enhance the central nervous system release of histamine. And it's going to be a strong, in fact, the strongest enhancer of cochlear blood flow that's been found is histamine. It has effects on other neurotransmitters, as I mentioned. The H3 receptor antagonism, or let's just say the use of beta-histine, will elevate the level of neurotransmitters, including serotonin in the brainstem. And this is important. Again, in addition to stimulating cochlear blood flow, histamine inhibits the activity, or beta-histine, I should say, inhibits the activity of vestibular nuclei. And that's why it plays such an important role in balance, or I should say imbalance. And it definitely has been shown, as we'll discuss here in a minute, that it can decrease rodeo symptoms. This is a graph showing the effect of histamine on cochlear blood flow. It's a dose response graphs. And what it's showing is that there's an augmentation of cochlear microcirculation, and it's quite dose dependent. If you're looking at, if we're starting out with our baseline cochlear blood flow with this, and you can see on this, we have differing doses of histamine. This is in the mouse, differing doses of histamine, and is 16 milligrams, 24, 48, and 160 milligrams. And these are given as an isolated, not a TID dose, but a single dose on this. And you can see there's a very much a dose-related response of histamine to cochlear blood flow. It levels out. Our maximum effect we get is giving these mice, these rodents, 160 milligrams. And beyond that, there is no increased enhancement of cochlear blood flow. And these are measurements, by the way, in the strial vessels. So what's its role in Meniere's disease? Well, first of all, as I always explain to patients, we don't really know what causes Meniere's disease. And then, we all get kind of creative in our explanation of what Meniere's is. But the bottom line is, whatever causes Meniere's, the end result is there's a relative overproduction of endolymph that occurs in the inner ear, in the membranous labyrinth. And it's going to periodically result in either stretching, rupture, or leakage through Might-Reiser's membrane. And the theory on why Meniere's disease helps is we do know that it will increase cochlear blood flow. And this is, again, where I get sort of creative just with description and saying, well, gee, we're coming in and kind of flushing out that, that extra sodium and potassium, sodium in the inner ear, et cetera, like that. But it does increase inner ear blood flow. And whatever else it does, that seems to enhance and shift the balance of endolymph towards more of an absorptive stage. In other words, if there's an overproduction, it shifts it to the other, more of a greater absorption back, or vice versa. So it reduces the symptoms of endolymphatic hydrops. Now, again, a disclaimer, beta-histine is not FDA approved for the treatment of Meniere's disease. Despite that, it is the most widely prescribed medication in the world used in the treatment of Meniere's disease. And I was recently, I don't know if I'd say fortunate or unfortunate enough to serve on the American Academy of Otolaryngology clinical practice guideline groups. We went back and re-reviewed our clinical practice guidelines and definitions of Meniere's, because the last time that has been done was in 1995. So the results on this we published last year. And our conclusion on histamine was that clinicians may offer diuretics and or beta-histine for maintenance therapy to reduce the symptoms or to prevent Meniere's disease attacks. We also concluded it's safer than diuretics by reviewing hundreds of pages of documents on this, and that it actually, to the best we can tell, it's more effective than a diuretic. So why isn't it approved? John may have some comments about this. I always understood there were some sort of like shenanigans that went on in some clinical trials, maybe someone who kind of fudged results or something like that, at least on trials in the US. And again, there are always these kind of rumors, but I don't know the specifics. In 1970, histamine was approved in Europe for the treatment of Meniere's disease. And we actually did approve it in the US. The FDA is also in the early 70s. and it was used as a vestibular suppressant for Meniere's. That's the way it was, considered, like an antihistamine for Meniere's. However, that approval was revoked after 5 years. And that's again where these kind of something about the clinical trials, drug efficacy. One of the questions that came up with the FDA is, gee, sometimes in these clinical trials, the definition of what we considered Meniere's might have been a little bit shaky. Were we sure they were Meniere's, et cetera, about this? And so today, if you look in the literature, you're going to get very conflicting data about how efficacious it is or isn't. Most of it's going to come from Europe. I only put this up. I don't think this group needs to review this. These for doing trials on beta-histine or montelukast or anything else. We have to be very anal compulsive about the Academy guidelines of following. These are definite Meniere's disease, so that we don't get into trouble with the FDA and have them revoke something that may work. And we also want to qualify if we think it's probable Meniere's disease. The difference on this are really the length of time in vertigos. Vertigo can last longer on probable Meniere's than definite Meniere's. And we can have symptoms on probable Meniere's versus those that are objectively measured with audiometric results. But again, these are for your references right here. This is the result of our Cochrane review on Meniere's disease and beta-histine. And the conclusion was most trials suggested a reduction of vertigo with beta-histine, and some suggest a reduction of tinnitus. But in all of these, the effects may have been caused by a bias in the methods, and that was in particularly true of tinnitus. There was one trial with very good methods, double-blind, placebo-controlled, et cetera, that showed no effect of beta-histine on tinnitus compared with placebo in 35 patients. None of the trials showed any effect of beta-histine on hearing loss, and no trial showed any serious adverse effects on beta-histine. And again, when patients ask, as they will push you, why are you using beta-histine? I'm very upfront with them about we actually have no medication that we've been shown clearly is efficacious for the symptom of hearing loss with Meniere's disease. Don't promise them tinnitus. I mean, these things are great. It's gravy if they get them, but not likely to happen. Here's subsequent cocaine reviews, 2014 and 15. Overall, the meta-analysis supported the therapeutic benefit of histamine for both Meniere's disease as well as vestibular vertigo. And I tend to prescribe beta-histine a lot for vestibular migraine as well. How well does it work compared to other treatments? If you really push the dose, like they often do in Europe, beta-histine 144 milligrams a day is going to yield similar vertigo control results as intratympanic dexamethasone. So can we use this information today in the age of COVID? And we definitely can. I know early on with COVID, I was very reluctant to use oral steroids in anybody who had a sudden loss, anybody with a Meniere's exacerbation. I mean, none of us knew what COVID was, the new variant, and we might just get it from walking outside a minute and who was going to die and everything else. So I was using pretty exclusively intratympanic steroids. However, as the COVID-19 has become a little more defined for us, or a little more studied, I guess I would say, we know that that dexamethasone is often used in patients, in fact, commonly used in the algorithm of patients with severe COVID who are especially in the hospital, low-dose dexamethasone. So it did not look like there was any contraindication to using a steroid if needed during the time of COVID in a particular patient or one with Meniere's disease. Clearly, if we look at guidelines on COVID vaccines, the FDA will state that there's probably not as good an immune response, though, in patients taking immunosuppressants when they get the COVID vaccine. So we do want to try to limit steroid use when we can. But certainly, this is where I began to switch a lot more to beta-histine for things like vestibular migraines. I started to add it in for sudden losses, things like that. And it does seem to, I think clinically, I've seen some improvement with it. I mean, I feel very comfortable in terms of an AE profile that's quite safe for most patients. And it is something that If they're not on beta-histine, they're having problems with Meniere's, they're only on diuretics, I'd say definitely consider switching them to beta-histine before we really come out with the steroids or even the other immunosuppressants. And by the way, beta-histine does not affect, the concurrent use of steroids with beta-histine does not have any effect on either of them. You can use them quite safely. You can also use beta-histine in patients with allergy shots. What are the pharmacokinetics of it? The peak onset of action is 1 hour. The elimination half-life is in 3.5 hours. It's metabolized in the liver. And it is the pathway involved is not the infamous cytochrome P450, but it does involve the monoamine oxidase inhibitor pathway. It's not affected by food intake, and it is excreted in the urine. How much should we use in patients with Meniere's disease? And this is a good question. Here in the States, as you all know, our typical dose we use is 16 milligrams TID. I see the occasional patient that won't tolerate that, and we have to go to 8 milligrams TID or 16 BID or something like that. The clinical trials, and that was one of the things the FDA objected to, because of the clinical trials, the doses given were from 4 milligrams to 48 milligrams TID. And again, in many of the trials, if not most, there was no placebo given to really study this. And again, not necessarily an accurate dose of Meniere's disease in the first place. So we don't get a whole lot of help from the clinical trials, the old ones, in terms of what dose to use. Now, strep, this is again from strep. I'm going to give you a couple of articles we reviewed on those Academy guidelines as to what's the best dose for you to use. And strep et al. Had 221 patients that they gave varying doses of beta-histine to. They had a double-blind placebo-controlled trial. So they gave either placebo, beta-histine 24 milligrams BID per day, which is the equivalent of what we're doing with 16, or 48 milligrams TID per day. It was a good trial. They had 9 months of treatment. They had 3 months follow-up, off the medication. And what they found was the trial did show a very significant decrease in the severity and the frequency of attacks of vertigo from baseline. But the trial was a bust, just like Famvir in terms of vertigo, because there was no difference in the dosage or placebo regarding the outcome. We know placebo effects are real. But this is a different study. Lazy has found a different result on his. And this wasn't as tight a study. It was an open label study. But what he did is he took his worst Meniere's patients. They had good diagnoses of Meniere's. He took 11 of them he could not control with his usual dose, which was 48 milligrams TID. And he treated them with, to us, huge doses of beta-histine. He gave them 288 to 480 milligrams per day, which comes out in split doses to 76 to 160 milligrams TID. And he found a significant reduction in severity and frequency in these patients that nothing else was working on. He had few adverse events with this, and none of the adverse events required any change in treatment. None of them were significant enough. So it's what this study did to me on this. The weakness of the study is obviously it's an open label study, but these are really bad patients and patients flunking everything. And to get some benefit like that, I think was pretty impressive. It also has let me feel much more comfortable in terms of pushing the dose if necessary on patients with Meniere's disease. I mean, I will, not be uncomfortable with going up to 32, 48 milligrams TID in these patients. So what's our usual dosage of beta-histine? Again, in the US, it's 16 milligrams TID. The Europeans, as a generalization, do typically use higher doses than we do in the States, probably because we're afraid, since it's not FDA approved, that, we're kind of like thin ice anyway. But they frequently will use 32 milligrams or 48 milligrams TID. The baggage on beta-histine, we all know it must be compounded. I'd say the majority of our patients now do get the beta-histine from Canada. I know at least in my side of the office that when I give them a prescription for beta-histine, I'll often give them two, one for the local pharmacy and then the other for Canada, because it may take 2 or 3 weeks right now with COVID to get that beta-histine back. And again, the brand names I think we're familiar with, Circ, Beta-Circ, or it may just be called the generic beta-histine. How safe is it? That is well established. Has no effect on driving, does not cause any sedation. You may take it with a non-sedating antihistamine or a diuretic. If that sounds counterintuitive, it really isn't, because remember, beta-histine has only a very weak H1 agonistic effect. It is mainly going to be an H3 effect for our purposes with this. And unless you're using a sedating antihistamine, then it's not going to get as robust an effect if you're doing that. But otherwise, you can use it with a non-sedating one. You can take it with allergy immunotherapy. I was quite concerned about that when I first came here. It does not affect asthma. Take it irregardless of food intake. As I mentioned earlier, that cytochrome P450 pathway, I can hardly believe there's a medication that doesn't involve it, but apparently beta-histine does not. Though again, a relative contraindication would be if the patient is on a medication they cannot stop, it's a Mayo inhibitor, then that you would want to consider whether to use beta-histine. What are the adverse effects with it? Again, it's got an excellent safety profile. There are over 130 million patient exposures since 1968. It's been approved for use in 80 countries, more than 80 countries. And a 35-year post-market surveillance showed 554 AEs were reported. They were all reversible. They were self-limited, primarily rash, pruritus, urticaria. So some patients got a little H1 effect with them. Nausea, vomiting on this. Some patients, perhaps they had some H2 stimulation peripherally. Headaches are rare with it. There's never been a death or anaphylaxis recorded from beta-histine. There was one non-anaphylactic, non-fatal Stevens-Johnson reaction. What are the contraindications? The usual. If you have a known allergy to beta-histine, don't take it. I don't prescribe it to patients who are breastfeeding, patients who are pregnant, just simply because we have no data on that. Gastric ulcer, I'd say is a relative contraindication. I don't typically prescribe it for that. I mean, I guess, you could say, well, there's, maybe try it along with an H2 blocker like famotidine or something, maybe, but I just tend to stay away from it with that because it's just, we haven't really established that well enough. It has not been studied in children under the age of 18, so it's not something I would use in a pediatric migraine patient. Fortunately, I rarely see pediatric patients with Meniere's. Asthma, I don't think it's a contraindication, frankly. I mean, it's, this is brought up that theoretically it could have some H1 effect and stimulate allergic asthma, but I have not seen that, and I'm quite comfortable in prescribing it with asthma. And then for the neurosurgical service here, you don't prescribe it in the presence of a known pheochromocytoma. So histamine research is moving beyond the non-sedating antihistamines and even beyond what we already know about beta-histine. There is a intranasal form of beta-histine that's being developed by Auris Medical. I know nothing about it other than that. And it's their target is for the possible treatment of Meniere's disease. The H4 receptor antagonists, I only touched briefly on H4, but they're being studied very, very actively, or they're already in preclinical trials for various pathologies, not Meniere's, but inflammatory. There may be a role for it with asthma, neuropathic pain management, inflammatory bowel disease, IBS, and even some forms of cancer. So in summary, histamine plays an important role in many immunological and neurological pathways. Its effects depend on which of 4 receptor sites it is bound to. The research strongly supports the fact that beta-histine does improve the vertigo and dizziness of Meniere's disease, although not the hearing nor tinnitus. AAO-HNS does recommend beta-histine as an acceptable therapy for the treatment of Meniere's disease. And again, the disclaimer, beta-histine is not currently FDA approved in the United States for use.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.